Hello, everyone, and welcome to our webinar. Today, we'll be talking about the fundamentals of US oncology pricing and why it's as much of an art as it is a science. So during this time, we'll be presenting some of the key considerations for developing a US pricing strategy for oncology therapies and how to holistically approach this and take a holistic approach that considers the most critical stakeholders for your product. My name is Nico Economides, and I will be one of the moderators today. I'm a director in our life sciences team at Huron. I'm based in Los Angeles, and I've been working in the pricing and market access space for the last 8 years. And I've spent my consulting career in both the EU and the US. Before I let my colleagues introduce themselves, I just want to point out that Dawn, Megan, and myself work in the Huron Life Sciences team. And this involves about 130 individuals that focus on the commercial strategies of our life sciences clients. And that, of course, includes pricing and market access. Feliz works in our healthcare practice, and one of the benefits of working at Huron is really that we bring together the life sciences team with people like Feliz that have that operational experience in hospitals and pharmacies, so that we can collectively work together in developing pricing strategies. Dawn, I'll let you go next.
Great, thanks, Nico. Hi, everyone. Don Creighton, Managing Director in the New York office. I have about 20 years of experience in pricing market access, split between industry and consulting. I started in a boutique consultancy, Cambridge Pharma Consultancy, which was acquired by MS, and then moved over after about 3 years into Pfizer for 9 years, where I was a global market access director in the specialty care business unit and the oncology business unit. And within the oncology business unit, I had significant experience at the launch stage, including Xalkori, Inlyta, Bosiliff. Moved back over to consulting with ICON Clinical Research, which has it's a clinical research organization, but has a consulting arm. And so I was there for 6 years, and the last 2 of which I was the head of the practice. And I've been happily with Huron now for 2+ years, working with the team. So nice to have everyone on, and we hope that this is informative and that you are engaged in terms of the Q&A. Megan.
Hi, everyone. I'm Megan Lambert. I'm a director with Huron Life Sciences. I've got about 6 going on 7 years of experience in life science consulting with a focus primarily in global pricing and market access. I'm based in our New York City office and wanted to thank you all for joining us today.
Hi, everybody. I'm next. My name is Liz Yusufay, and I'm a licensed pharmacist that's board certified in oncology. I'm a manager in the healthcare practice at Huron, and I have over 5 years experience in medication use and reimbursement, hospital operations, and specialty pharmacy. So prior to moving over to consulting, I worked at an NCI designated cancer center as a clinical specialist. There I worked with hospital administrators, and I was an active member of a P&T committee. I'm really excited to speak with you all today regarding oncology pricing strategy and offering the hospital and clinical perspective. Thanks.
Thanks, Feliz. So just to let you know what our plan is, we're going to be presenting for the next 30 or so minutes, but we do want to leave time at the end for a Q&A. So we'd ask that you submit your questions through the Q&A function in Zoom, and we'll get to as many of those questions as we can at the end of the presentation. So why are we here today? Well, we know that over the last 5, 10, or even 20 years, we've seen really significant advancements in cancer care, particularly when we think about pharmacological treatments. We've gone from having only a handful of chemotherapy regimens to targeted therapies, and then we saw immunotherapies, and most recently we have cell and gene therapies, like CAR-T. So these products have really had an important and profound impact on the lives of cancer patients and their families, and they've increased survival, and in some cases they've turned what was a fatal diagnosis into a chronic illness almost. Other products have also reduced symptoms and have improved the quality of life of patients. So really, really an important impact here on patients or for patients. But all this amazing innovation has been in the context of rising healthcare costs. So we know that these innovative oncology products are not cheap, and the cost of healthcare overall is increasing, and we're hearing more and more that affordability is becoming a serious issue. We're also seeing that the political climate is quite rapidly evolving, and we've seen some significant healthcare reform, including the Affordable Care Act. We've seen other reforms, some of which have specifically targeted drug pricing. For those of us who watched the presidential debate this week, you will have noticed that drug pricing came up. So this is likely going to continue being in the spotlight in the future. And of course, all of this increased scrutiny on the price of oncology products has given us quite a lot to think about. And for those of us who are directly involved with it, it's given us a lot to consider. And particularly in oncology, where we're thinking not only of what we call the gatekeepers, such as payers, and also, of course, the end users, which are the patients, we're also frequently considering the court of public opinion and how price is perceived by the public. And it's important to consider where a pricing strategy fits in to the overall creation and also the dissemination of value to the healthcare system. So we internally think about this in terms of the three elements of value governance. So you create value, and creating value is arguably the most important driver of commercial success. The value that you generate, for example, extending survival or improving toxicity and quality of life, that's what leads to an impact on patients, and as a result of that, on the healthcare system and just society in general. It's also, however, important to create value because this is the foundation that you're going to build your pricing strategy on. To capture value, the pricing strategy must ensure that you're sufficiently capturing the value reflected in the clinical evidence, but you're doing it in a way that optimizes revenue. And this process for doing that is not always straightforward, and that's the big reason of why we're here today. And finally, the communication of value, that doesn't only suggest that we need to communicate how great the product is to budget holders like payers. We need to leverage that clinical value and really provide support and the sound rationale for the price. With that, I'm going to hand over to Megan, who's going to walk us through the next few slides.
Thank you, Nico. So when we think about how we actually go about supporting our clients in developing a robust pricing strategy, as the title of this webinar suggests, we really believe that it is as much of an art as it is a science. But we'd like to start with the science and how we employ the scientific method. So we have our key questions, we develop our hypotheses, and then we test these hypotheses in our research. And then based off of the analysis of the results of our research, we draw conclusions that inform the development of the pricing strategy. Two key pieces of research that we conduct include primary research with payers to understand the price and access trade-offs, as well as research with prescribers to understand the impact of price on access, or price and access on utilization. And the payer research is really looking to assess willingness to pay and expected coverage or utilization management or restrictions based off of price. While physician research, we're looking to understand the baseline prescribing expectations in a situation where price and access is not an issue, and then how that expected prescribing might change, if at all, based on the price and access environment. Often this physician perspective captures the patient perspective as well, but we may also need to conduct research with patients to understand sensitivity to out-of-pocket payment scenarios. All of this has the ultimate goal of understanding price elasticity. And then what we can do is we can dovetail the insights from coverage and utilization to get an understanding of really how much of the potential eligible patient population could be retained in a given price and access environment. And this is really critical because we want to make sure that we are developing our pricing strategy with a view to ensure that as many appropriate patients get access as quickly as possible. But based on that retained value, we can retained volume, we can also determine the impact of price on revenue potential. So ideally, we'd see an inflection point. We'd see a change in payer and prescriber behavior that reveal, as Nico alluded to earlier, a revenue optimizing price. But in oncology in the US, the challenge is that the scientific method can't fully inform the strategy because there typically isn't that clear-cut inflection point. Payer willingness to manage in oncology has historically and is still quite limited. It's considered to be a protected class, and patients and prescribers tend not to be price sensitive. And so we don't necessarily see that same inflection point that we would see in other therapeutic areas like diabetes, for example. And this is what really necessitates a need for a more holistic approach, one that's multifactorial and really considers the nuance in launching an oncology product. So when we think about what is required to develop a comprehensive, robust pricing strategy, as we've discussed the science of our research, we may not see a clear inflection point. And so we have to go beyond that standard approach and really take into account more subjective information and to determine the pricing strategy. And this is where really the art comes in. We consider a broad variety of different factors, but most of them fall into these 6 key buckets. The first is comparators. So, really, what are the current products that may serve as direct or indirect price references for stakeholders? The next is taking an even broader look at payer management to understand the implications of price for patient access. And then we have additional stakeholders. So Feliz will talk about in a few minutes that beyond just the payers, when we're developing a pricing strategy, we need to understand who the other stakeholders are that play a role in determining access to new therapeutics. And to what extent does price really impact that decision-making process? For utilization, as we just mentioned, if we can go back one slide. For utilization, as we just mentioned, it helps us understand how prescriber behavior and patient fulfillment may vary based off of price and/or access scenarios that are a result of the price. And then we have executive alignment, which Nico will walk us through as well. But we need to ensure that our senior executives and board members are really on board and in support of the pricing strategy. We know that these key stakeholders internally can have their own perspectives or opinions on what is or is not appropriate from a pricing perspective and what's in line with a corporate strategy. And sometimes they may have already communicated some of this externally. And so we need to be aware and incorporate this into our pricing strategy process. And finally, public perception. As Nico already mentioned, there's a lot of scrutiny on drug pricing in general, particularly in oncology. Products are evaluated in the court of public opinion. And so when we're developing the pricing strategy, we need to be considerate of how the price may be interpreted or perceived by the public and the media. So in the next few slides, we'll talk about a few of these elements in more detail. I'll start us off and pass over to Feliz and Nico. And then Nico will also help to explain how we sort of take all of these considerations and organize them and evaluate them systematically to inform a final pricing recommendation. And just a reminder as we go, if you have any questions, please feel free to submit them into the Q&A option. So the first one is that we typically start with is the comparators, because evaluating the direct and indirect pricing comparators helps us to establish what are the benchmarks, what are the potential thresholds, and really begin to define the pricing corridor. So typically we start by looking at direct competitors or price references, what's the standard of care, what's currently being used and paid for today. And in addition to looking at just the prices and the access environment for those products, we need to understand the value proposition and how the value proposition of the new entrant compares. So what are the positive or negative differentiators, and how might those translate into a relative premium or discount to get to a potential value-based price? If there are no direct competitors or perhaps just inappropriate price references, or maybe we're just trying to be super comprehensive, we would evaluate additional benchmarks as well. Looking at analogs, like for example, we could look at all of the oncology products that have launched in the last few years, or brand-on-brand combination therapies to get sort of any key findings there. But because there are no perfect analogs, we just need to make sure as we do this that we're really being considerate of the context of the launch. So it's not just looking at what was their launch price, but really understanding the full story in terms of the competitive landscape, again, the value proposition, the corporate strategy, so that we can ensure that any of the insights that we identify are actually applicable to the product that we're working on. For payer management, that's the next slide. But for payer management, we mentioned sort of coverage and utilization restrictions already, but we need to get a full picture, and often that requires looking at other elements of payer management. So, of course, we do have to do the primary research to understand the utilization restrictions. I'm not sure if I'm on a lag, but I think we might need to go to the next slide. Okay, perfect. Great. So we discuss the primary payer research that informs an understanding of price and access trade-offs. So that'll tell us really at given price what's the expected coverage and utilization management or payer restrictions. Willingness to manage in oncology has typically been limited in the US. As I mentioned, it's a protected class, and so we often hear an expectation of the product will be covered on the highest available tier with a prior authorization to label. But we know that this is evolving, and we're beginning to see payers preferring products within certain mechanisms of action, such as the PARP inhibitors, for example. And this is something that may continue to take place, and we need to make sure that when thinking about a new product coming to market, that we're being forward-thinking. Contracting, we know, has also historically been limited in oncology, but we also need to understand that as the whole marketplace is evolving, what is the potential need for or benefit of contracting, including value-based contracting, which some manufacturers and some payers might be interested in. In terms of the pharmacy versus medical benefit, it's not quite as easy as it used to be, in the sense where the route of administration used to drive what benefit a product was covered under. But we are seeing a lot of payers shift drugs towards the pharmacy benefit, which can have significant implications for patient out-of-pocket contribution, as co-pays or co-insurance can vary significantly between medical benefit and pharmacy benefit, depending on the plan. And site of care dynamics is similar. So we see a general trend in the industry of shifting patient care to a lower acuity setting or a less expensive setting. So we see inpatient to outpatient, outpatient to home, and pharmaceuticals are no exception in this. We are seeing some payers, for example, even requiring IV immunotherapies to be given in the home setting. And this is definitely something, if it's relevant for the particular product, that we need to understand the implications of as it relates to the price. And finally, it's a bit more macro, but just the benefit design overall. So what are the trends in terms of employer benefit strategy? What are the plans that they are gravitating towards? We are seeing an increase in high deductible plans, as well as plans with significant cost sharing. My husband's open enrollment is due today, and there are several plans that have extremely high deductibles that are options available to us. So we're living it, but we also understand that, this is a reflection to a certain extent of the economy, and COVID will likely have an impact on the types of plans that employers are offering their employees as well. All of these, on the right-hand side, the benefit design, the site of care dynamics, they're really informing the patient accessibility. So from a financial perspective, a lot of these drive the out-of-pocket burden, which of course impacts affordability. From a geographical and logistical perspective, we need to be considerate of whether or not the patient can actually get to the appropriate site of care or physically acquire the product through a specialty pharmacy, for example. So these obviously have an impact on the overall uptake of the product, the fulfillment. So after the prescription, does the patient actually get the product? But it's also an important consideration when we think about the additional resources that may be required from the manufacturer in order to support access to the patient and the product. And depending on the organization, this may have a significant impact on the pricing strategy overall. So beyond payers, I mentioned that there are other stakeholders that can impact the access, and I'll pass it over to Feliz to walk us through those stakeholders.
Thanks, Megan. So as we heard about before, pricing strategy for oncology therapy had typically been driven by historical benchmarks and payer pricing research. But as we know now, with U.S. healthcare expenditures continuing to rise, there's been a greater focus placed on controlling spend, especially in regards to these high dollar specialty treatments. So to ensure that we have a holistic view on price, it's important to consider additional stakeholders who may potentially influence the way medications are used and accessed. One such stakeholder are hospital administrators. So hospital administrators are directly responsible for health systems budgets as well as formulary decisions. So one such strategy that's often used to manage spend is formulary restrictions. So what this does is it limits where a drug can be infused, so in a patient care area, or it will limit where the drug can be used in a specific disease state. One such example of this is when they restrict a drug to be infused in the outpatient setting when reimbursement is usually higher. Another stakeholder to consider are group purchasing organizations, or GPOs. GPOs are entities that work with health systems and physician practices to source and negotiate discounted drug prices. Typically, GPOs work with large networks of health systems or provider practices in order to leverage their volume to get these discounted pricing. GPOs also have a professional services arm that they use to educate these organizations about competitive drug pricing. And they really are the eyes and the ears and that these organizations need to learn about cost containment and as well as revenue enhancement. For example, physician networks can utilize GPOs professional services to learn about competitive drug prices in order to select treatments that will help them maintain their revenue. The final stakeholder to consider are clinical pathway developers. So clinical pathways are decision support tools that are developed by providers, payers, and third-party vendors. The goal of a clinical pathway is to maximize evidence-based care while minimizing total healthcare costs. As interest in value-based contracting and healthcare continues, pathways are increasingly being used by health systems, physician networks, and payers. While in theory they're very beneficial, clinical pathways can potentially limit a physician or a patient's choice to choose something that's not on the pathway, and often treatment choice is linked to a financial incentive. So altogether, the role of these stakeholders and their influence in oncology treatment must be considered to really get a well-rounded view on pricing. And what we really want to understand is, to what extent does the price affect the willingness to pay for a product, and can that impact the way an oncology treatment is accessed and utilized? So to describe the executive alignment and communication regarding price and value, I'm going to pass this off to Nico. Thanks.
Thanks, Feliz. So if you recall the 6 pricing strategy factors that Megan presented early on in that circle, executive alignment and public perception are the last 2 components, and both of these are related to price communication. So we think about price communication in terms of internal and external communication. And part of what we do is to think through and provide rationale for both those pieces of communication, internal and external communication of price. When we think about the objectives or the desired outcomes of internal and external price communication, for internal communication, the desired outcome is to get executive alignment on the price recommendation. And for external communication, our desired outcome is to ensure that the price is positively received by all the relevant stakeholders that are outside of the manufacturer's organization. And to do this for both internal and external communication, we follow the 3 principles that you see at the bottom of the slide. So the first principle, price communication must align with the corporate strategy. So you could be working on the first oncology product launching for your company, or you could be working for a product that is part of a vast oncology portfolio. Either way, though, it's important to make sure that we are aligning the pricing strategy with whatever the vision is for either the brand or the company, the oncology franchise in general. So it's important that we align with the corporate strategy. The second principle notes that we must sufficiently capture value in a way that optimizes revenue. And this is a really important point for external communication with stakeholders such as analysts or shareholders or investors, because you really want to put forward and demonstrate that the price that you have set captures the value of the product. And lastly, it's important to make sure that there's a robust rationale for price based on the clinical value. So this is the kind of messaging and rationale that's going to be used by the manufacturer with all of the interactions with the broader clinical and healthcare community. So it's important to make sure that there is a robust rationale for price based on the clinical value. And I mentioned at the beginning of the presentation that the court of public opinion is quite important in oncology, and we often spend quite a bit of time considering that last part around public perception. And this often includes us doing further analysis, and that kind of analysis could be us looking at appropriate analogs where we assess how their price was perceived at launch. An example is whether there was a negative perception of the price at launch and whether that could have impacted uptake. Another example is whether price caused any lasting damage to the reputation or the manufacturer's relationship with either payers or providers. So we tend to dig into that stuff and make sure that the price that we're recommending is appropriate based on this analog assessment. And this is an example of how we take what is often quite a subjective factor and tie it into our price setting process. Okay, so how does it all come together? So it's not only important for us to consider all the key components, the 6 key components that we presented, but in order to translate those into a pricing strategy, we use a framework, and we call this the alignment framework. And that reflects the relative priority of these factors. So when we're using this alignment framework, we lay out the key factors that we want to consider in our pricing strategy, and then we determine what thresholds we want to apply. So for example, if we're talking about what is the appropriate premium to the comparator, the answer to what that threshold is can be based on some of the research that we did. Maybe we talked to payers, maybe we talked to physicians, but it can sometimes also be based on some internal discussions that we had with stakeholders within the manufacturer organization. And it's important to note that the key factors that we include in our framework here, we have the illustrative example on the slide, those map back to the 6 core pricing strategy components that we've presented today. So the analysis and the research that went into each of those 6 components that we've talked about help us determine what the thresholds as well as what the relative weighting of each factor in this framework should be. And this is our process and how we quantify and prioritize the objective together with the subjective measures in order to arrive at a pricing recommendation. And this is our last slide. I just want to recap very quickly and say that in this presentation, we've shown you the 6 key factors that we consider in the pricing strategy. We've explained why they're important and also how we quantify and prioritize them so that we can arrive at a pricing recommendation. There are, however, very often other important factors that we need to consider, and we don't want to discount these. So we definitely want to also be mentioning them today, but always taking them into account. And these can be often therapy area specific, or sometimes they can be dependent on other things, like, for example, which payer or provider segment you're working in. And we've listed some of the most important factors that we consider on this slide. An example is the clinical guidelines, such as NCCN and ASCO guidelines. These are always important, but there are definitely times when the guideline recommendation is pivotal for the positioning of a product. So we really, really need to understand what the positioning of the product is going to be, which is going to be based on the clinical guideline. And in that case, it's a very important or a more important factor to consider in the pricing strategy. Payer contracting is another example. As Megan mentioned earlier on, it's not something that we necessarily consider or see a lot of in oncology, but it can be important for the pricing strategy in certain high competition therapy areas or high competition therapeutic classes, or if a product is truly undifferentiated versus the standard of care. Another example is healthcare reform. With the presidential election looming, it's likely that there's going to, or we will continue to see quite a lot of talk about this and about the cost of oncology products. And any manufacturer would be quite wise to factor that into any pricing decisions they are making. In a nutshell, that's our approach for pricing an oncology product in the US. In the remainder of the time, we'd be happy to answer any questions. So if you have not done it already and you have a question, please submit your questions via the Q&A function in Zoom.
So I'll be fielding questions, and just to go back to this context here in terms of the contracting, there's payer contracting, there's also GPO contracting mentioned here, and we certainly have heard from providers that utilization is driven, particularly when you see a lack of differentiation through the contracting with the GPOs, because a significant part of their equation in terms of utilization is practice economics. So you know, which product, again, if there's a lack of differentiation, is the practice going to make more money by using? So something that we do incorporate in. Again, it depends on the context as to whether it's a very innovative treatment or if you see a lack of that differentiation. And so there are spaces that we all know where there is that perception, where there isn't sort of distinct clinical value between products. Okay, so I'm going to take a few questions. There's a few here. There's one specifically on pharmacy versus medical benefit. Like, what trends have you observed, and how this affects the buy and bill, and how strong have you observed the pushback from physicians? So as we know, with the providers, again, the recovery cost as it relates to buy and bill can be a key driver and a key revenue driver. And so there is concern, I think, from the providers that there is a concerted effort by insurers to reduce that incentive. And it's not just insurers, it's the reforms that you see in terms of ASP plus whatever margin that is, particularly within Medicare, which continues to decrease. But we do see the, for example, I think one of the comments earlier from Megan and Fliz was speaking to this as well, is this restriction, this site of care restriction. And we see some of the larger plans now restricting site of care to home care for the IOs. And that's a pretty big move. And you can understand that their desire to do that is because that is a high budget, high margin space where the payers want to, again, limit that sort of recovery cost incentive that they see from the provider side. There has been significant pushback. I would actually go to Fliz on this one too, because she based off her former career, she has people that she's spoken to specifically on this issue as it relates to trying to push back on these restrictions. My understanding is to no avail at this point, but Fliz, maybe you could speak a little bit more to that given our previous conversation.
Yes, definitely. we have seen this a lot with our clients as well in the academic medical center space. So especially with the IOs, yes, home care, but also increasingly these large health plans have their own specialty pharmacies. So they're trying to drive these higher cost drugs through their specialty pharmacies to keep, so they're not paying the infusion center for the cost of the drug, they're only paying them for the cost of the infusion. And so what they end up doing is they will fill the IO medication, and then the patient will bring the vial into the infusion center to infuse. So that's just a nightmare in a hospital operation sense, but you know, they've pushed back, they've written letters, and they haven't really had a lot of success. There has been a client who made the statement, you know, if we're going to see a lot of these individuals and this X payer is going to do this, then they can go somewhere else, that we won't see them at our facility, that they can go. So it's all still pretty new, but we are seeing significant trends in this direction. So it just really depends on the market that the hospital's in and what their payers are, how big of an impact this is. And
that's, and to some extent, we alluded to COVID, and COVID could potentially continue to expedite these types of things, because people will have a higher willingness for home care. We've heard really interesting. We had a roundtable where they were talking about a virtual hospital. So there's a lot of things going on right now in the U.S. and elsewhere as it relates to keeping people out of the hospitals, keeping people out of clinics, and so you know this moves things in a new trajectory. And with that, there was another question on the impact of COVID and what will that have on price setting methodology. And currently there's not really a clear change in methodology. I think it goes back to like the nuances that we were talking about as it relates to our alignment framework, and really thinking through those things, and regarding how does COVID affect the patient journey, and therein the access journey, as we call it. And that's something that we're continuing to reflect on. Huron has a huge healthcare practice, which Fliz works within, and we're doing a lot of work with hospitals. That's the key part of that practice, is basically working within the hospitals. And we're now even moving towards helping institutions with testing and tracking and the like. So there's a lot going on in that side, and that will help us understand the patient journey and the access journey as it relates to the relevant reimbursement mechanisms, and if that has impact on price. So I would say that the jury is still out from our perspective on that, but certainly that's something that we are continuing to evaluate. The one other aspect is just in terms of cost. I think for COVID has been a significant factor in terms of cost, not only because of testing and the like, but also because of the state of the economy. And so obviously from an economic standpoint, states rely on taxes, the federal government relies on taxes, and when that money's not coming in, that impacts Medicaid specifically, but it also can impact Medicare. But with Medicaid, when we're talking to our clients, whether it's a pediatric disorder or a mental health disease, we really have to think about how COVID and the economy, the state's economies, are going to impact payers' willingness to pay. And so that's something that we have had conversations with already around Medicaid payers, and I think that's certainly something that we will continue to consider. And again, that can then indirectly relate to, as Nico mentioned, healthcare reform, because as budgets get tighter, there may be additional reforms to basically hit on, to focus on the low-hanging fruit, which unfortunately is our industry within healthcare and pharma, versus the hospitals or or the other stakeholders, such as the physicians, because they'd be less likely to direct, cost constraints on those areas versus pharmaceuticals. As you can tell, I've worked in policy for 5 years, so that's certainly something that I've lived with for a long time, and in terms of, again, the focus on pharma. Okay. So another question on the pricing strategy analysis framework, and elaborating on how that fits in with the 6 core strategy components. So I think, as we referred to, the sort of the art and the science, or the creative and analytical aspect of thinking about a pricing strategy, as we go through the research, we have to creatively think and analytically think through what makes sense as it relates to the key factors associated with an alignment or framework. And there are certain things which are very clear. For example, if you have an oral product, then ASP management will not be part of that equation. That will not be a key factor. But and as we just talked about, whether we think it's going to be a medical benefit and pharmacy benefit, but practice economics maybe, as we talked about, in terms of if there is another therapeutic that is perceived to have similar efficacy. So we basically go through the research. What's really important in this process, and something that I've lived through and went through Pfizer, is thinking about executive management and others, and say you have a commercial committee to go through, and thinking about their expectations. What is their perception? How they may already have a price in mind, and you need to really consider the context around that as part of your alignment framework. And so, Nico, Megan, and I have basically talked to CEOs and board members, and that part of that process is going through that alignment. And it's an effective manner to have that conversation and gain alignment on a final price. But hopefully that answers the question. But again, it's both, as Nico said, objective and subjective in terms of the information that's provided, and also, again, relative to sort of what we're hearing internally in terms of expectations and perceptions of value. Okay, just looking to see. Another question: have you seen any payer? Have you seen any payers to reimburse ASP? I'm sorry, I'm trying to interpret the question. Like a higher margin for ASP for a low-cost ASP drug. Medicare ASP is set, so that's not something that really is that really you see in practice. You do have in the commercial side, you have different ASP margins, and those are negotiated by the plans. We hear anything from 6 to 9 to 12 and from the commercial side, and that's typically where the practices make up. If they have a loss, or they're sort of at parity or neutral on the Medicare side, they'll maybe have a pickup from the commercial side. And that's why it's important to understand the payer mix, because you need to understand sort of how the practices are thinking about this as it relates to their Medicare and commercial population typically. But no, that's not something we typically I've witnessed. I've been remiss in actually asking Nico, Megan, or Fliz if you have any other comments, maybe as it relates to the pharmacy medical benefit, or COVID, or the alignment framework. Any other thoughts, comments?
I think you were quite comprehensive, Don.
Yeah. Okay. 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 So are there any other questions from the gallery? We'd be happy to take them. Okay. Okay. I think that's all right. Okay. Well, hopefully this has been a useful, constructive presentation for you. We work in this space a lot, and we try to put a lot of thought into developing these strategies and the context around the strategy. And we hope that this provides just some sense of how we think about it and how you can think about your own strategy going forward. So I think with that, we'll, if there's no other questions, both on chat or from our Q&A, I think we'll close.
Yep, thank you everyone. I just want to make a note that you'll all be receiving a recording of this presentation also. So thanks for attending.
Great. All right. Thank you.